Hello everyone, my name is Satyajit Patra. In this session, I'll be discussing pharmacogenomics of breast cancer and therapy. We'll talk about the challenges in this session. Breast cancer continues to be the leading malignancy diagnosed in women in Western societies. It is estimated that 268,670 women will be diagnosed with breast cancer, and about 41,400 women will die of breast cancer in the United States in 2018 alone. Breast cancer is the most common cancer in women worldwide, with nearly 1.7 million new cases diagnosed in the year 2012. With an estimated 41,400 deaths to occur in 2018, breast cancer is the second leading cause of cancer death among women in the US and worldwide, with women experiencing the highest mortality rate. Breast cancer mortality among younger women with age less than 50 in particular is higher compared to that of younger women. In the latest data, it also suggests that among women 20 to 49 years of age, breast cancer mortality is the largest disparity among cancer specific diseases and had widened over the past 30 years. Menopause does not cause cancer, but risk of developing cancer increases as the woman age. So women going through menopause have a greater chance of developing cancer because they are older. Treatment of breast cancer is constantly evolving as new technologies, agents, and strategies are being discovered. Advances in the early detection and adjuvant treatment of breast cancer have already led to significant reduction in disease related relapse and death. However, there is significant variation in drug response and survival outcomes in individuals treated with equivalent regimens, including hormonal agents, cytotoxic agents, and novel targeted therapies. Traditionally, clinical and histopathological factors alone have been used to guide choice of therapy. These factors include tumor age, tumor size, nodal status, and intratumoral characteristics such as grade, expression of estrogen and progesterone receptors, and HER2 status. These factors may be prognostic, that is, indicating the aggressiveness of a tumor and likelihood of relapse without systemic therapy, or predictive of response to specific treatments, or maybe both. In recent years, advances in technologies such as the sequencing of human genome, development of high throughput DNA analysis, and popularization of the idea of personalized medicine have led to a significant interest in how differences in genetic makeup may be used to predict treatment safety and efficacy. In the last decade, there has been an increase in number of studies investigating the role of pharmacogenetics in the treatment of breast cancer and other cancers. The term pharmacogenomics or genetics refers to a study of the influence of patients' genetic makeup on their response to drug therapy, including toxicity and efficacy. Technology's advances have allowed the rapid assessment of gene expression and function. This includes assessment of both tumor, that is somatic, and host cell, that is germline genetic variation. Tissue microarrays, for example, permit the evaluation of expression pattern of thousands of tumor genes, which have been proven critical in providing prognostic and predictive information regarding specific biologic subset of cancer. Genetic variations may be in the form of DNA alterations, including nucleotide repeats, insertions, deletions, or substitutions. The alterations of one nucleotide, a single nucleotide polymorphism, SNP can lead to absence or altered enzyme activity and thus to a significant impact on disposition of and or response to a drug. These alterations may affect drug toxicity and efficacy in a variety of ways. Changes in the coding region of DNA may result in amino acid substitutions in the translated protein, and changes in the non-coding region of DNA which can alter different aspects of protein function compared to a wild-type protein. The goal of pharmacogenomic studies is to identify genetic alterations such as SNPs that considerably affect the function or expression of proteins involved in pharmacokinetics or pharmacodynamics of therapeutic drugs. The ultimate goal of selecting a particular drug for patient based on their genetic makeup is to improve efficacy and safety. Till date, numerous studies have been conducted not only focusing on drug targets but also on cell cycle control and apoptosis, DNA damage and repair, and drug metabolism and transport. There are many things to be considered. These studies have attempted to correlate SNPs with breast cancer outcomes and translate the results to clinical applications. Several pharmacogenetic tests are commonly available and can be used to determine SNPs in individual patients. However, whether these tests should be used in the clinic and how they should be interpreted remain a challenging question. In this session, we will talk about the evidence till date regarding the role of patients' genetic in predicting both toxicity and response to therapies that are commonly used in breast cancer. We will discuss hormonal agents, Trastuzumab, and other targeted therapy as well as common cytotoxic agents. The common cytotoxic agents are these are the common cytotoxic agents. What? Let's discuss about hormonal therapy. Nearly two-thirds of breast cancers are classified as estrogen receptor positive, which is prognostic for improved survival outcomes and predicts responsiveness to endocrine manipulations. By binding to either ER alpha or beta, estrogen regulates a variety of cellular effects and physiological conditions, including breast cancer cell proliferation. Though not always considered in this manner, endocrine therapies are indeed breast cancer targeted therapies as they treat cancer by blocking specific receptors, which prevent or inhibit tumor growth. Several hormonal agents are approved for the prevention of treatment of breast cancer, including selective estrogen receptor modulator, that's SERM, tamoxifen, raloxifene, as well as third generation aromatase inhibitors, anastrozole, letrozole, and exemestane. While the final common pathway of both SERMs and aromatase inhibitors is to disrupt estrogen signaling, both classes of drugs undergo vastly different metabolic routes of elimination and activation, and each of these metabolic steps is under genetic control. Thus, genetic variations that alter the proteins involved in metabolism, uptake, or distribution of each drug could provide useful predictive information for therapeutic recommendations. Tamoxifen. Tamoxifen is the most widely SERM and is the standard adjuvant hormonal agent initially prescribed to women with hormone responsive early breast cancers for over 30 years. The early breast cancer trialist collaborative group reported that 5 years of tamoxifen therapy is associated with a reduction in relative risk of breast cancer recurrence of approximately 40%, and the breast cancer mortality is reduced by about one third yearly throughout the first 15 years following randomization. Even more recently, analysis of the worldwide adjuvant tamoxifen, longer against shorter trial, has suggested that 10 years of effective endocrine therapy can approximately halve the breast cancer mortality during the year 10 to 14 after diagnosis. In addition to worldwide spread, in addition to widespread use of this adjuvant setting, tamoxifen is effective palliative care therapy in women with hormone receptive positive metastatic breast cancer. It is almost approved for women with ductal carcinoma in situ and for prevention of breast cancer in high risk. Tamoxifen remains the drug of choice for menopausal women with breast cancer. In postmenopausal women, tamoxifen is often used in sequence with aromatase inhibitors or as a single agent in women with a contraindication to aromatase inhibitor therapy. Cytochrome P2D6 activity. It is a predictor for tamoxifen-associated outcomes. While variants in several genes encoding tamoxifen metabolizing enzyme have been correlated with tamoxifen-associated outcomes, variable activity of base pertinent cytochrome P450 brought about by genetic polymorphism and drug interactions may alter the balance of tamoxifen metabolites, thereby altering its effect. While there are several genes of interest in tamoxifen metabolism, the one that has been generated the most press has been CYP2D6, which encodes the enzyme responsible for metabolism of N-desmethyl tamoxifen to endoxifen. CYP26 is a polymorphic gene with more than 100 reported allelic variants. Often due to SNPs, common allelic variants in this gene are associated with the effect of N-desmethyl tamoxifen metabolism and subsequently with in vivo concentrations of endoxifen. This observation has led to hypothesis that allelic variation may predict responsiveness to therapy with tamoxifen. This theory has generated great interest, studies, and even practices changes over the last decade. In general, patients have been classified as extensive, intermediate, or poor metabolizers based upon their CYP26 allelic variant. Although prospective or retrospective analysis has been disappointing, more information is awaited from prospective clinical trials designed to collect the data on CYP26 polymorphism and response to tamoxifen shown in this table over here. The Eastern Cooperative Oncology Group, the E3108 trial, represent an attempt to correlate CYP26 activity with progression-free survival in metastatic breast cancer patients through collection of germline DNA and high-quality prospective data. Another example is French neoadjuvant phase 2 study evaluating CYP26 polymorphism in non-metastatic patients and responsive to tamoxifen prior to surgery. Korean Astra study aims to assess the impact of CYP26 genotype on the clinical effects of tamoxifen using samples from prospective randomized multicenter study. Next, aromatase inhibitors. In contrast to tamoxifen, the third generation aromatase inhibitors, anastrozole, letrozole, are considered active in parent form, and metabolism serves as means of inactivation. These drugs function by inhibiting the enzyme aromatase, which is encoded by CYP19A1 gene and is responsible for the conversion of androgen to estrogen. As this primary source of estrogen in postmenopausal women, the third generation of aromatase inhibitors inhibit about 99% of in vivo aromatase enzyme activity, and thereby decreasing endogenous estrogen concentration far below those caused by natural menopause. Several randomized trials comparing aromatase inhibitors and tamoxifen as adjuvant hormonal therapy have been demonstrated significant improvement in disease-free survival and reduction in breast cancer event. Aromatase inhibitors are, however, associated with bone loss and musculoskeletal adverse effects. And it has been postulated that these aromatase inhibitors related effects may correlate with pharmacogenetic variations, may predict improved treatment efficacy. Targeted biologic therapy. Drug of choice is Trastuzumab. Trastuzumab is humanized monoclonal antibody that binds specifically to the HER2 receptor and suppresses cell proliferation that is driven by overexpression of HER2 protein. The combination of trastuzumab with chemotherapy has led to significant reduction in breast cancer recurrence and mortality in HER2 overexpressing or amplified tumors when used in the adjuvant settings. Trastuzumab efficacy is believed to be in large part due to the engagement of Fc gamma receptor or immune effector cells, which leads to destruction of tumor cells, a process known as antibody dependent cell mediated cytotoxicity or ADCC. Despite extreme improvement in the outcome of with the use of trastuzumab, not all women whose tumors are HER2 positive will benefit equally with adjuvant trastuzumab, and metastatic patients treated with trastuzumab will eventually progress during therapy. Given variable response, significant risk associated with treatment include cardiotoxicity in 5% of patients and substantial cost involved. Identification of genetic markers predictive of trastuzumab response is quite interesting. Studies on pharmacogenic trastuzumab have been mostly focused on polymorphism of Fc gamma receptors. In an analysis of 54 metastatic breast cancer patients treated with trastuzumab, investigators reported that the Fc gamma R3A158 VYV genotype was significantly correlated with objective response and progression-free survival and possibly associated with higher trastuzumab mediated cytotoxicity. In a single arm study of trastuzumab in patients with metastatic breast cancer, Fc gamma R3A158VV genotype was significantly correlated with response and progression free survival. However, other studies do not support these findings. In the largest trial to date on the Fc gamma receptor 2A and 3A polymorphisms, investigators tested samples from 1,189 patients enrolled in the trial, analyzed several Fc gamma receptor polymorphisms without any significant relationship between multiple SNPs, disease-free survival in trastuzumab treated patients. Unfortunately, these conflicting results preclude use of tests for these SNPs to predict trastuzumab response for further study into these factors underlying variability in trastuzumab response is required. Bevacizumab. Bevacizumab is a humanized monoclonal antibody targeted against vascular endothelial growth factor or VEGF-A, which stimulates angiogenesis and thus can promote tumor growth. The first molecularly targeted anti-angiogenesis drug, the story of bevacizumab in breast cancer has been dynamic. Bevacizumab was initially approved for the metastatic breast cancer in the year 2008, following the E2100 intergroup phase 3 trial comparing weekly paclitaxel alone with paclitaxel plus bevacizumab as first-line therapy for metastatic breast cancer. This approval was upon further data collection. Dependent on that, When data failed to demonstrate a significant benefit in the year 2010, the FDA advisory panel recommended against breast cancer as an indication, and this was officially withdrawn from the approved list for use in breast cancer in the year 2011. Additional studies is required to determine the role of this drug in the adjuvant settings for breast cancer. Cytotoxic chemotherapy. It is well known that most patients have narrow therapeutic index to cytotoxic drugs and may react differently to administration of equal doses. As with the use of hormonal agents and other targeted therapies, not only clinical and histopathologic features but also pharmacogenetics may partly explain individual differences in the safety of and efficacy of cytotoxic agents. Antimetabolites. Capecitabine is an orally administered prodrug of the pyrimidine analog 5-fluorouracil, which is frequently used in the treatment of metastatic breast cancer. Capecitabine is enzymatically converted to 5-fluorouracil and inhibits DNA synthesis with tumors, thereby slowing growth of the tumor. Dihydropyrimidine dehydrogenase (DPD) is an enzyme encoded by the DYPD gene, is the rate limiting step in pyrimidine catabolism and deactivate more than 80% of standard doses of 5-fluorouracil and the oral 5-fluorouracil prodrug capecitabine. Up to 5% of the population lacks the DPD enzyme, and this has been associated with excess drug accumulation and toxicity. Additionally, an estimated 5% of the population has sequence variant of in the DYPD gene, and these pharmacogenetic variants may be linked with 5-fluorouracil toxicity. Multiple DYPD variants have been identified, including well-known non-synonymous and splice site variation within the coding regions of the gene, and more novel variation within non-coding regions, and their association with 5-fluorouracil toxicity has been replicated in multiple studies. Further metabolite profiling of patients and comprehensive genetic screening of DYPD has been proposed to further refine the understanding and relative contribution of individual DYPD variant to the risk of severe 5-fluorouracil related toxicity. In addition, DYPD variations in the genes encoding for thymidine synthase (TS) and methylene tetrahydrofolate reductase (MTHFR) may affect outcome in treatment with capecitabine as well as toxicity. In a prospective pilot study of advanced breast cancer patients, increased toxicity and significant shortened duration of response was observed in patients homozygous for thymidine synthase variant allele. Similar to capecitabine, gemcitabine nucleotide analog that inhibits DNA replication and thus induces apoptosis of tumor cells. Gemcitabine is approved in treatment of metastatic breast cancer either alone or in combination with other agents. In patients with advanced breast cancer treated with gemcitabine, the degree of hematologic toxicity, tumor response, and survival may be affected by the presence of variant enzymes. In one study, which analyzed SNPs in genes encoding for deoxycytidine kinase, deoxycytidine monophosphate deaminase, and ribonucleotide reductase M1 polypeptide, investigators demonstrated that a ribonucleotide reductase haplotype was associated with a lower frequency of chemotherapy induced cytotoxicity, such as neutropenia, growth factor requirement with gemcitabine monotherapy in breast cancer patients. Variant ribonucleotide reductase RRM1 have been associated with response to gemcitabine in multiple diseases, and studies are being conducted for to define its prognostic and predictive utility. Antimicrotubules. The taxanes, that is paclitaxel, docetaxel, are some of the most effective chemotherapeutic agents against breast cancer and are indicated in both metastatic and adjuvant settings. Taxanes disrupt microtubule depolymerization and spindle formation during cell proliferation, thereby causing cell death. Both paclitaxel and docetaxel are hydroxylated in the liver by CYP3A4. Paclitaxel undergo further metabolism by CYP2C8 and docetaxel undergoes further metabolism by CYP3A5. Transport of taxanes across cell membranes occurs via influx transporter SLCO1B3 and efflux transporter ABCB1, ABCC1, ABCC2, and ABCG2. Added to standard anthracycline based regimen in the adjuvant settings, taxanes result in significant reduction in the risk of cancer recurrence, breast cancer mortality, and overall mortality. Anthracyclines. Anthracyclines such as doxorubicin and epirubicin have been widely used in breast cancer treatment for several decades. This class of drugs inhibits topoisomerase II and thereby induces apoptosis of cells. Pharmacogenetic variations have been observed in genes encoding anthracycline metabolism enzyme, drug transporters, and enzyme influencing oxidative stress and apoptosis. Approximately 50% of infused doxorubicin is eliminated in its intact form. The metabolism of remainder of doxorubicin is complex and involves a variety of enzymes, principally aldoketoreductase, carbonyl reductase, NADH dehydrogenase, nitric oxide synthesis, both NOS1, NOS2, and NOS3. Cyclophosphamide. Cyclophosphamide, a backbone of breast cancer treatment, is incorporated into most adjuvant breast cancer chemotherapy regimens. Like tamoxifen, cyclophosphamide is a prodrug that undergoes two phases of hepatic metabolism, with initial metabolism to 4-hydroxycyclophosphamide, primarily mediated by CYP3A4, CYP2B6, CYP2C9. The main active metabolite is aldophosphamide, which is then detoxified by aldehyde dehydrogenase 1A1. Many other cyclophosphamide metabolites can be deactivated by irreversibly binding with glutathione, a process which is catalyzed by glutathione S transferase A1 and P1. There is significant variability in plasma concentration of cyclophosphamide metabolites between patients, which suggests that there may be a role of genetic variability in determining cyclophosphamide metabolism. These are the classes of drugs which are used for treatment of breast cancer. What are the ongoing investigations? As the field of pharmacogenomics has taken off, there has been an explosion of data, as suggested by many studies reviewed earlier. And the realm of bioinformatics has developed to keep pace with increasing amount of data. In the year 2000, the NIH initiated the Pharmacogenetic Knowledge Base, that is PharmGKB initiative, with a goal of creating a repository of primary data to track association between genes and drugs, and to catalog the location and frequency of genetic variation known to impact drug response. As new technology shifted research from candidate gene pharmacogenetic to phenotype based pharmacogenomics over the past past couple of decades. The Pharm GKB has refocused on curating knowledge rather than housing primary genotype and phenotype data, and now captures more complex relationship between genes, variants, drugs, diseases, and pathways. Moving forward, the challenges are to provide the tools and knowledge to plan and interpret genome-wide pharmacogenomic studies, predict gene-drug relationships, and support data sharing among associations investigating clinical applications of pharmacogenomics. Thank you.